Good morning and welcome to Pediatric Grand Rounds. As always, the CME code is in the chat box and we'll keep repeating it. It's my great pleasure to introduce this morning's Grand Round speaker, Dr. David Stukas, who is a professor of clinical pediatrics and the director of Food Allergy Treatment Center at Nationwide Children's Hospital at the Ohio State University College of Medicine. He holds several national leadership positions, including as a current vice president of the American College of Allergy, Asthma, and Immunology. Dr. Stukas received his MD from the University of Pittsburgh School of Medicine and did his residency in pediatrics at Nationwide Children's Hospital, and then served also as a chief resident at National Children's Hospital in Ohio. Subsequently, he did his fellowship in allergy immunology at Cleveland Clinic. Dr. Stukas has published more than 100 peer-reviewed publications and 2 textbooks. And today he's going to educate us on practical guide for food introduction and allergy prevention. Dr. Stukas, thank you very much for accepting our invitation. The floor is yours.
Thank you so much. Thanks for the invitation to join you. Good morning, everybody. It's a pleasure to be with you today. What I'm going to talk about is something near and dear to my heart. And as you see, as we go through things, I hopefully will present information in a new perspective for you all that may hopefully adjust the way that you communicate with families. And believe me, we'll have plenty of time at the end for questions, and I have no doubt there will be some. Here are my disclosures, which aren't relevant to what we're going to discuss today. And here are the objectives. We're going to talk about the confusion surrounding infant feeding. I'm going to give you the best practical advice I possibly can, and then really talk about ways we can anticipate parental concerns during those visits that you have with them throughout your day, including this morning. Here's my goal. So I want to give you new perspective. Everything I talk about will be evidence-based information. This isn't just Dave's opinion here. This is me serving as a conduit to give you all the published, guidelines and research and things like that, and then hopefully help you appreciate, your very important role in helping families feed their babies and ideally prevent food allergies. So when we talk about this, we have a lot of outdated information, which I'm going to address sort of right off the bat. We have wonderful new evidence and guidelines, which I'll share with you. And this is how we develop progress. And I think it's a good thing for all of our families and their babies. So before we begin, I think it's always important to acknowledge the enormous elephant in the room when it comes to this topic, because I think we've done a very good job as a medical establishment at confusing parents and frankly scaring them at feeding their babies. And a lot of it has to do with our own guidelines and flip-flopping evidence and things like that. So I think if we go in this with some humility, and when we talk to parents about how this is what we once thought it was and this is where we are today, and acknowledge how confusing it has all been, I think that's a very good starting place for all of us. So how did all this start? Well, in the year 2000, the AAP published guidelines in regards to food allergy and in feeding infants, and it basically said no milk until 1 year of age, no eggs until 2, no nuts, peanuts, or seafood until 3. If you're pregnant or breastfeeding, avoid all of these things. Just 8 years later, which is a remarkable turnaround when it comes to national guidelines, they said, well, hold on a second. Maybe we don't need to avoid these things, but if you feel like it, you can introduce them. It wasn't an active guideline to recommend get these foods in the diet. It was more of a passive suggestion. But just within 8 years, it's very confusing, and a lot of people still held on to the 2000 guidelines. 2015 was a pivotal landmark trial. I'm sure you're all familiar with the LEAP trial. This was the first prospective randomized controlled trial that demonstrated if we introduce peanut into an infant's diet before 1 year of age and keep it in their diet consistently up till 5 years of age, compared to those infants who avoided it, there was an 86% reduction in peanut allergy at 5 years of age. This was remarkable. This changed everything for us in regards to our understanding of tolerance and food allergy prevention. 2017, I was part of the US guidelines that we wrote, and we said we should test babies for peanut before introducing it when they're at risk to develop allergies, specifically those with moderate to severe eczema. That was based upon one study. I frankly think we jumped the gun a little bit, and we're going to talk about screening and things like that. And then in 2021, we also reversed and wrote the North American guidelines, which basically said no need to test. So flip-flop after flip-flop after flip-flop. All that to say is, did we fix it? We have no idea. This is a hard thing to study in regards to prevalence of food allergy. I'll share some data about how we're still not consistent with talking to families, but this is why it's been so confusing for all of us. There was a survey a few years ago talking to U.S. parents, 3,000 of them. Only 13% were aware of the peanut guidelines. Half of them didn't really understand that if you introduce foods early, we could prevent food allergies or decrease the risk. Half still felt that it wasn't safe to introduce peanut prior to 12 months of age. And then 40% said their pediatrician never really discussed this with them. So that was a few years ago. We don't have really good data since then, but this is something that we need to continue to monitor. So here's a common scenario when it comes time
Turn
to
it down a little bit.
introducing foods to babies. A lot of parents are just scared out of their minds. I don't know about all of you, but I have families tell me that they've driven to the parking lot of the emergency room before they feed peanut to the baby the first time. And that's heartbreaking because this should be a really fun, milestone when we start introducing solid foods to babies, and we want to try to provide that reassurance. There's a lot of messaging that's been displayed over the years, but I'd like to correct some of that with the actual evidence. So for years, I think people have been told that babies are more at risk to have severe reactions because they're small, they're nonverbal, they have little airways. The reality is it's extremely unlikely for a severe reaction to be the presenting food allergy reaction. Almost always, 97% of the time, it's going to be some combination of hives. Maybe they vomit once or twice. That's how I get patients as a pediatric allergist. I don't get patients because they end up in the ICU the first time they eat peanuts. So we really want to reassure families, even when food allergy reactions occur, they're almost always more mild and self-resolved. I don't know where this came from. It's a very conservative approach to introducing foods, but the message has been only one new food every 5 days, 7 days, once a month, things like that. There is zero evidence to support this. This is an ultra conservative approach. And now I'll share evidence with you where we actually want to promote, let's give multiple foods, even all at once, because odds are nothing's going to happen. And if something does happen, we can go back and sort it out and clarify what's going on. Some parents have been told to just rub a little bit on their skin first. We don't want to do that for two big reasons. One, you're going to get non-specific rashes that it's going to raise alarm and cause unnecessary angst. And number two, that's a great way to sensitize people to allergens, whereas we want them to eat it to promote tolerance and expose it to the amazing immune system involved in the gut. The message has always been, well, food allergies can occur the third time you feed your baby, or the fourth, or the seventh, and you're never really out of the woods. Your baby's a ticking time bomb. The reality is, no matter what we do, 92 to 95% of babies will never develop a food allergy. So we want to flip this on its head and reassure people. And I'll talk about risk factors in a moment. And then the message has been that eczema must be because of something you're eating. And that is completely false. And I'll share all that with you as well. So I just want to lead off at the bat of some of the flip-flopping and inconsistent sort of recommendations that have been placed over the years and where we are with our current understanding. So let's talk about some of the hot topics right off the bat, and then we'll talk about some practical tips. So atopic dermatitis or eczema and allergies are intricately linked, but allergies don't cause eczema. Eczema is a chronic skin condition hallmarked by a defective skin barrier with a very complex immune pathology underneath the skin. And allergies can play a role, but that's not why people have eczema. When we look at systematic reviews, this is a great one published in the last couple of years. We look at does food elimination improve eczema? I'll cut right to the chase. Dietary elimination may lead to a slight improvement in eczema severity for some patients, typically those with the most severe eczema that's refractory to treatment. However, the degree of benefit is potentially unimportant compared with the risk for harm, because what happens is if we start removing food from the diet of babies with eczema and they're already making IgE, but they're not reacting to that food, and then they avoid it, that's when they can develop an actual food allergy that can transition to hives and anaphylaxis. So that can cause real harm. The most recent atopic dermatitis guidelines or practice parameters were published about a year ago. There is a recommendation we suggest against the use of elimination diets. Again, it can cause harm. It's not going to provide much benefit. And most importantly, right now for atopic dermatitis, we have dozens of effective therapies. And we're moving beyond just topical corticosteroids. We have calcineurin inhibitors, we have JAK inhibitors, we have biologics. So we can fix the skin without removing food from the diet. This is one of the most common diagnoses that I see at our food allergy treatment center. It's L24.6, irritant contact dermatitis due to food in contact with the skin. We have a beautiful blonde hair, blue-eyed, fair-skinned baby who starts to eat things like tomatoes and strawberries and ranch dressing and citrus, and they get rashes around their mouth every time they eat. This is not a food allergy. These children are often well-appearing. The foods that are causing these rashes are uncommon causes of food allergies, such as fruits and purees and things like that. This can come and go over time, and this can occur for dozens of foods. So we always want to make sure we clarify the diagnosis, but we don't want to raise alarm when we have a well-appearing infant who gets a rash when they eat cinnamon and things like that. Other things that are not due to food allergy. So we know that colic is not a food allergy. Reflux is not a food allergy. It's a physiologic condition. These are things that you can find online and in social media. Fatigue, chronic abdominal pain, migraines. It's interesting because these are some conditions that may be worsened by certain food. Like we know migraines may be triggered by foods that have tyramine, for instance, or caffeine. You're not allergic to those foods. You have the condition that may be worsened by that. Same thing with reflux. I have reflux. If I eat a dozen buffalo wings, it acts up. I'm not allergic to buffalo wings, but that's an example of that. Diaper rashes are not caused by food allergy. Changes to the bowel pattern, chronic hives are not caused by food allergy. Same thing with bloating and things like that. So when we see these very common concerns from parents, we can reassure them that it's not due to an allergic reaction to any specific food. Then we talk about this nebulous diagnosis of quote unquote cow's milk allergy. And there was a recent review of the guidelines published regarding cow's milk allergy over the past decade. And basically, they attributed this diagnosis to every symptom imaginable, from rashes to colic to poor sleep to reflux and things like that. They also talk about how maternal breast milk really doesn't contain a lot of allergenic protein. So 99% of the time, it's not going to pass through and cause any symptoms. And then there is a conspiracy because a lot of these guidelines are actually written by folks who have conflicts of interest because of their work with industry and formula manufacturers. You
David,
froze.
yeah, we cannot hear you. You're frozen. David, you may have disconnected. I'm trying to reach him.
Okay, Deepak, can you hear me now?
Yeah, we can hear you. We lost you with
Yeah,
that.
I am so
Maybe you
sorry.
got.
We had like a power surge or something like that, but
Oh, okay, okay.
I'm back.
Yeah, I was trying to reach you too, and I could not get hold of you. Anyway,
Yeah, I'm so
so
sorry. Where did we
go
stop
back.
at the cow's milk allergy?
Yeah, that's very. So you have to go back a little bit. Yeah,
Okay, is this a good
yeah,
spot?
here. You
Okay,
will.
I
Yeah.
apologize, everybody. I heard this beeping and I asked what it was going on, but that was me. Okay, we're back. All right, so so as we transition, I think it's important to talk about this diagnosis of quote unquote cow's milk allergy, which is often overdiagnosed. And there was an interesting review in JAMA Pediatrics a few years ago that looked at recent guidelines, and they found that a lot of them actually included symptoms that are just nebulous and not really due to allergies, such as just rashes or colic or reflux or things like that. They also, looked at maternal diet. It rarely, if ever, passes intact cow's milk protein through the breast milk when they're breastfeeding. And some of these guidelines, there is significant conflict of interest with people who had connections with industry and formula manufacturers. So there are good guidelines now. It's through the World Allergy Organization. There's a 12-part series. I encourage you to read this on your own. I've shared my slides. You have all the references, but this really talks about using milk elimination as a diagnostic and therapeutic trial. And it acknowledges that this diagnosis of cow's milk allergy is overused. It can also be underused. We talk about the elimination diet in a second. And then reintroduction. We don't need to wait until 12 months of age for dairy, because a lot of times these are benign conditions that resolve on their own, or it's actually not due to milk allergy. This is the most common presentation. I apologize for those of you eating breakfast right now. The cow's milk-induced allergic proctocolitis. You have an otherwise well-appearing infant who's growing normally, acting fine. You change their diaper and you see gross red blood, or you have hemoccult positive. That's the more common presentation for this. So when we go back to the guidelines, it talks about if you consider this diagnosis in an infant of cow's milk allergy, we can do a trial elimination diet. So if they're on cow's milk-based formula, you can put them on a soy formula. If we think that it is passing through maternal breast milk, we can do a maternal dietary elimination, but do it for 2 to 4 weeks. We don't need to eliminate it for 6 months or 9 months. Do symptoms completely resolve? Then put milk back in the diet. Do symptoms come back again? If not, it's not cow's milk allergy or whatever it was, it's resolved. If they do come back again, then remove it for a period of months at a time. If you take it out of the diet and symptoms do not completely resolve, it's not cow's milk allergy. Put it back in the diet and consider another diagnosis. So we can really use these much shorter elimination diets now. And the reason why is because the vast majority of these infants that have this diagnosis, there's another cause, or it's a self-limited benign condition. So I think we can just be more thoughtful and more helpful for families when it comes to this. And this goes for breastfeeding mothers as well. So I think it's now well recognized that blanket recommendations for mothers to eliminate certain foods from their diet due to conditions in their infant really are probably incorrect. This is a great review article, and it really talks about how a thoughtful approach is necessary, and we want to minimize unnecessary diets. I have so many mothers in my practice that are just in tears because they've taken out dairy and egg and wheat because of, improper reasons such as eczema in their infant or reflux or colic or stuff like that. And their baby either doesn't get better or they've gotten better just because tincture of time is what fixes this. And these mothers stop eating these foods, or they blame themselves because they slipped up and had some butter in their meal or something like that. Here's the algorithm. So if you are going to recommend that a mother remove food from her diet, it really starts with what's the diagnosis. So what are we diagnosing the infant with? If it's eczema, as we talked about before, that's unlikely to be due to the diet, and especially food passing through. So we don't need to even recommend that. Is it GI symptoms? Again, what's the diagnosis? If it's reflux, that's not going to be, specific food related. Is it cow's milk allergy? We can do a trial elimination and things along those lines. So just being more thoughtful to help the families that we care for, I think is going to be important. And then lastly, this is a great review article that really looked at how much intact allergenic protein passes through breast milk. And they found that there's less than 1 in 1,000 actually had intact allergenic protein pass through the breast milk. So it's pretty rare. Even in infants who have IgE-mediated peanut allergy anaphylaxis, those mothers don't need to stop eating peanut. They're not causing allergic reactions after breastfeeding. So again, it's a complete reversal of what many of us have taught, the way we've practiced, but it all goes back to just being more thoughtful in how we're recommending these things for families. All right, so now we talk about the outdated, incorrect approaches and these rapidly evolving, new evidence and paradigms, and it's enough to make your head spin. So let's talk about food introduction. We know that these babies that have eczema are raising their hands saying, I'm going to have an allergic life. So oftentimes their eczema resolves within the first 1 to 2 years. They may or may not develop food allergies. They may or may not develop environmental allergies as they get older, than asthma. But this is the common progression that I see in my practice, at least on a regular basis. We can't prevent eczema, unfortunately. There have been many trials that have done that. They've even using emollients from day of life one. It can delay the onset or lessen the burden of it, but we can't actually prevent that. We can't prevent asthma. There's no interventions that can do that. There's no good way to prevent allergic rhinitis, but we do actually have ways that we can potentially prevent food allergy, which is what we're going to talk about next. So why should we try to do this? Well, we know that food allergies are relatively common. They affect about 8 to 10% of children, depending upon what studies you read. They can be lifelong, especially when it comes to peanuts, tree nuts, seafood, sesame. So it can be a big burden for throughout their lives. It can put them at risk to have allergic reactions. It can also cause decreased quality of life. While we do have treatment options available, we don't have a known cure for food allergy. So if this isn't a call to arms to do everything we can to try to prevent this from happening in the first place, I'm not sure what is. So what are risk factors? I think we can now, stratify infants into low, medium, and high risk to develop food allergy. Family history is actually not a very strong risk factor. So we know that parents don't pass specific food allergies down to their babies. So we have a lot of parents that have their own history of peanut allergy and they're afraid to feed peanut to the baby, but that actually isn't a very strong risk factor. So we don't need to worry about that so much. The age of introduction can be a risk factor. If we delay this and we wait until kids are over a year of age, that may actually put them at risk to develop food allergies. And then the severity of their eczema. So it's not like that little patch that gets better with some topical cortisone and it just keeps coming back over time. It's those infants that have, a large body surface area that's affected, or they require more potent topical corticosteroids to control their disease. Those are the ones that are at highest risk. So the one thing we can modify, we can't change the family history. We can treat eczema, but we can't prevent it from happening, but we can modify the age of introduction. So that's what we can target. Now, hopefully we can all agree, and if you're not familiar with the literature, I'll go through some of it, but we have study after study after study and meta-analyses all showing that the earlier we introduce allergenic foods into a baby's diet, and most importantly, keep it in their diet consistently. It's not try a little dab of peanut butter and then wait 6 months before you try again. It's keeping it in the diet consistently and diversify their diet. This is our best path towards preventing food allergy. Is it 100% effective? No, nothing we do in medicine is 100% effective, but this is what we want to recommend as much as we possibly can. However, we have to balance this. So for those families that if they don't hit this window and they haven't tried it, we want to reassure them that it's going to be okay and we can still introduce this. We don't need to avoid it because they haven't had it by 12 months of age or things like that. Here's just a nice little, you can see all the different odds ratios and things like that. So the meta-analysis, we have over 14,000 children that look at this. The evidence is strongest for peanut and egg. But it's also accumulating for milk and other foods. But I mean, it's robust evidence that early introduction, ongoing inclusion is the best path towards preventing allergy. But these are some of the things that parents have been told traditionally of. My pediatrician told me to see an allergist before I introduce these foods. I'm too scared to give peanut. Again, as we talked about earlier, we've done a really good job at scaring parents. And people want to be tested for everything, or they think that their child's eczema is caused by food and stuff like that. So we can address this and reassure families as much as we can. But how do we make this happen? Well, it's going to take all of us. So you're on the front lines. You're meeting these families at their well visits. So this is hopefully a conversation that even obstetricians are having. And there's been some interesting quality improvement studies that look at, can we have this, conversation about solid food and allergenic food introduction during pregnancy before the baby's even born. But we're going to have to do this, all together and systematically to make this work. So the timing does matter. So we know that for prevention efforts, we really want to get this before the disease sets in. Earlier the better. There's a risk that actually increases over weeks to months. So it's not like, we want to go for between 4 to 6 months of age once they're already showing interest in eating other solid foods. So we want to start with the typical purees and things like that, and then we want to introduce the allergenic foods. But it's okay if they don't hit that window. But the risk does increase after 6 months and in between 6 and 11 months. So that's what we want to promote. In addition, we want to use good science to talk to people about the latest evidence. So when it comes to anaphylaxis, there was a great update to our practice parameters that was published last year as well, and they address certain things with infants. So when it comes to infant anaphylaxis, I'll read some of the consensus-based statements. We suggest clinicians be aware that in infants and toddlers, age does not correlate with severity. As we talked about at the start of this, it's unlikely for infants to have truly severe life-threatening reactions the first time they react. We suggest clinicians be aware that anaphylaxis is unlikely to be an initial reaction. We suggest clinicians be aware that parents of infants and toddlers may report age-specific symptoms. So for babies that can't verbalize, maybe it's more subtle and it's just they have, acute onset irritability and crying while they're developing hives after eating a food. That can be a presenting symptom. And most of these are going to be hives and vomiting and not anaphylaxis. So when we look at all of the guidelines that have been published, it's interesting because the United States is the only one that has their latest guideline or the last guideline that recommends screening with testing prior to introduction. For the rest of the world, that's all looking at the exact same evidence. They suggest not testing before introduction, and we'll talk about why. So there's some pitfalls if we screen. So from a caregiver standpoint, we can cause undue anxiety. They may think that they have to have a test done for food allergy before they introduce the food, or there's really distrust in these changing guidelines. For the clinician, it is well established that IgE tests are grossly misinterpreted. That leads to overdiagnosis and misdiagnosis. It can give an inaccurate, diagnosis and unnecessary avoidance. Plus, it takes time to get them in to be, to get referred and tested and things like that. So we can delay the introduction and miss this critical window. And it's also not very cost effective. And, with the disparities in access to specialists, we have to address that as well. So when we overdiagnose food allergy, this is where these screening tests come in. So there's no indication to ever order just like a panel of IgE tests for food allergies. And I know all of you have these folks coming into your practice saying, wouldn't it be great if you could just test your patient's blood, tell them everything they're allergic to? Well, that's not how these work. So the IgE tests only detect sensitization. They don't actually diagnose allergy. When we know 40% of children are sensitized to things like egg, milk, peanut, and shrimp, but only 5% are allergic, we're overdiagnosing the vast majority of them by using these tests. So we don't want to use these as screening tests. And we go back to, first days of medical school or undergraduate education, we talk about, all right, what makes a really good screening test? When we think about IgE tests for foods, it doesn't meet any of the criteria. So these have never been screening tests and they shouldn't be used like that. There's tons of false positives and they get, grossly misinterpreted. So when we talk about those families that we're seeing, there's different ways we can have the conversation. So for those parents that are having the first baby, no concerns. My advice is just proactively discuss the benefits of early introduction. We want to introduce these foods in your baby's diet around 4 to 6 months of age and keep them in the diet on a regular basis. If it's their first baby and they have a lot of anxiety, we want to anticipate that. And then we can discuss the risks and benefits of different approaches, talk about why we don't want to wait for testing. We don't need testing. We can provide reassurance as much as possible. And then for those that already have children that have food allergies, we want to proactively address this and say, listen, I know you went through this with your older child. Here are current recommendations. We can provide reassurance as best we can. And again, discuss the risks and benefits of the different approaches. But this is where the art of testing comes in. And believe me, I see parents every day that I need to see the negative result before I feed this to my baby. And I get it. So the medicine says don't do screening, but that's not real life. And we have some families. So we want to identify those with true anxiety and really discuss the risks and benefits. And before I do any testing, I ask them, is this going to change how you do it? Like if we have a negative test, will you go home today and introduce these foods to your baby? Or I'll say, if we have an elevated test result, I'm not going to diagnose your baby with an allergy to something they've never eaten, but maybe we'll do it here in the office. So here's my spiel. Feel free to borrow this at will. Take a screenshot. You have my slides. Here's what I say to families pretty much every day. There's no medical indication to test before introducing any food to your baby. I meet enough parents to know that some need to see a negative result to give them confidence. I'm happy to test for select foods if a negative result will help you go home and introduce today. If we see an elevated result, I'm not going to diagnose allergy, but we can easily have you introduce that food in my office if that's okay. So even after this, sometimes I say, now what foods would you like to be tested for? And every once in a while they just say, well, everything. And I kind of go, all right, well, let's go back to the top. I can't test for everything. So why are parents so scared? So there's a lot, our cognitive biases are very powerful forces in our lives. So, they don't want to make the wrong call. They're riddled with what if scenarios. And what if they introduce too early and cause a reaction? There's a lot of guilt that comes like that. They're more likely going to recall negative events than positive ones. So they're not going to go back and say, well, we introduced 25 foods and nothing happened. It's going to be that one food that may have caused rash or symptoms or stuff like that. They want to do everything they can to avoid that painful outcome and go for the easy stuff. The emotional state can really impact the decision they're making. We often see this, especially in babies, that have not, had a hard, first couple months of life, whether it's colic or poor sleep or reflux. And these parents are exhausted and they're not quite sure what to do. And they really want to avoid any potential future regrets. So we can address all this with the way that we discuss this with families. But we also have to talk about why are we so scared? So there's a lot of conservative, approaches towards, pediatric care that have been adopted over the years. Most of us, we're just really bad at assessing risk. And hopefully with all the evidence that I gave you today and the latest guidelines, it gives you that reassurance of like, hey, we're not actually going to harm these babies by doing this, and we're going to benefit a lot of them. And then ultimately, who are we to tell parents when to feed their baby? Like, this is them feeding their baby. Like, if they want to feed a food to them, that we shouldn't be telling them no. We should be supporting them and talking about it. So what's the risk if something does happen? Well, they could have a reaction at home. We may lose their trust after having that conversation. But what's the reward? Well, odds are they're going to do great. They're not going to have food allergies, and that we're going to have a happy family. This is a really interesting phenomenon because we're never going to know which children we prevented food allergy from occurring in, right? So this is something we kind of have to go in, not with blind faith, but we don't know the outcome. If these kids don't develop food allergy, we don't know if that was going to happen with or without early introduction, but we sort of have to trust the process. So what are some practical approaches for all of us to take just for our own sort of understanding? I think it's important to assume the best, not the worst, because that's what the evidence shows is going to be the outcome the vast majority of the time. We can anticipate these concerns and talk about it at well visits, and we can provide them with education and resources to help support them as best we can. Now, when we talk about like how much do we need to give and how often, a lot of this is sort of made up based upon prior studies. So there's no exact amount. I don't want you to get hung up on details, but there's a great resource here in this chart. If you do want, some families, especially those that are like engineers, they need to see the numbers and the details, and they say, do you tell me exactly when to do it and how much? And I'll hand them this. So when it comes to peanut, we can just use thinned peanut butter. There's peanut puffs that we can use, peanut powder we can mix into things. And we want to do this at least 3 times a week, 1 to 2 teaspoons. That's generally about 2 grams of protein. So when it comes to an egg, we want to, cook this up, chop it up as much as we can so they can tolerate it. This can be scrambled eggs or finger food. About 1/3 of an egg is a good starting point. And then when it comes to dairy, we can do things like yogurt or just formula if they're taking that, or cheese and things like that in 2 to 4 ounces. There's not great evidence for things like tree nuts, wheat, soy, sesame, and seafood, but these are some guidance that we can offer them. And really, it's, especially when it comes to seafood, a lot of families don't enjoy seafood. So they say, do I need to force my child to eat this? We don't have it in our house. I say, listen, odds are they're not going to have an allergy to seafood, regardless of when you give it. If it's not part of your family's regular diet, I don't think you need to go out of your way to make sure that you give this to them on a regular basis. So there are, ways that we can keep this simple. So if we focus on practical tips, this is something from the Canadian Allergy Society that really has a nice little infographic that walks through 4 main steps. We want to give messages such as, keep it in the diet as consistently as possible. Don't worry if you miss a day or two, but the point being, don't avoid it on purpose. It could be worse if you just give it like once every 3 or 4 months. That's how we may create allergies. So we want to avoid doing that if we can. If for whatever reason they're not going to do this, then we say, okay, that's fine. Just avoid it, and we can deal with this as they get older. And then we need to make ourselves available if and when concerns arise. So when we talk about the advice that we give, it really depends on who's that person in front of you. Are they highly anxious? Well, then we can offer in-office introduction. And now some of you may not be able to do that or feel comfortable doing that. That's where hopefully you have a good relationship with your community allergists. But this is something I recommend all the time. Like, listen, if you're too scared to do this, come to the office. My personal record was we introduced 11 different foods at the same time to a 9-month-old. She got a little rash on her chin. Her mother was highly anxious, wondering if I was going to send her down to the emergency room. And I said, no, this is fine. Like, this is not an allergic reaction. So it was a wonderful visit to give reassurance. Or if we want to start at home, like start with the stuff that doesn't cause allergies, fruits and vegetables, cereal, grains, things like that. If they're moderately anxious, you can say, listen, if you have concerns with some of the allergenic foods, it's okay to do it at home. Offer a few small bites and take a break. Monitor them for the next 5 or 10 minutes. If they're not fussy, if they're not developing hives on their skin, basically double the amount they're getting every 10 minutes or so till they eat a serving size. And then that can give reassurance as well. If they're mildly anxious, then we can say you can do this at home. You can try several foods in the same group all at the same time. And then if something occurs, we can go back and clarify what the cause was. And if they're not anxious at all, just talk about how they can offer several new foods in any amount. I mentioned before how it's just incorrect to say 1 new food every 3, 4, 5 days, because that's assuming that something is going to happen. We can now offer, you can try a dozen new foods today if you want. Now, we all know as pediatricians that it can take time for these babies to really like the tastes and textures and learn how to like these foods. But there's no reason not to take that approach if you feel comfortable. Here are some things I recommend you don't say. Please don't advise people to drive to the ER parking lot before introducing a food. That just is going to put their anxiety on level 12 out of a scale of 1 to 10. We don't want to recommend rubbing it on their skin first. We don't want to send the message that reactions can occur basically at any point, because then all they're hearing is that their child's a ticking time bomb. We don't want to tell them, like, keep them awake for a certain period of time after eating, because that again sends a very fear-based message. We don't want to prescribe epinephrine auto-injectors prior to feeding, because again, that's a very fear-based message, and it's extremely unlikely they're ever going to need to use that. And we also don't want to sort of chastise and say, if you don't get it in their diet by 11 months of age, then you missed the window. So we want to support them wherever they are in their journey, and reassure as much as we possibly can. So what about reactions? Well, this is a question I'm sure all of you get, and I get as well. They say, okay, what if I do this? What if they do react? Well, let's talk about this. We say the most common reactions will be some hives. If they do have some hives after that, if they're otherwise acting fine, those are going to self-resolve. If you want to treat it, we can use something like a second generation antihistamine. We do want to recommend not using things like diphenhydramine, because it's very outdated. They make kids drowsy. They have tons of side effects. Second generation antihistamines such as cetirizine, loratadine, they actually work faster than first generation antihistamines. They last 4 times as long, and they don't have those terrible side effects. So that's what we can counsel families to give in the right dose. If they have hives or stuff like that, we can put it in context. So if they're going to have a reaction to what they're eating, it's going to happen within 1 to 2 hours of eating. So if they get a rash, or they get fussy, or they vomit 12 hours after eating something, that's not a food allergy reaction. All of the symptoms that can occur due to food allergy can occur for unrelated reasons. So we want to put that in the context of, if they're going to react, it's going to happen pretty fast, typically while they're in their high chair at the table eating. We can review the common signs and symptoms, and then we can also anticipate, all right, as you expand your child's diet, here's a couple of things that are going to happen. One, their stooling is going to change. They're going to poop a lot more. It's going to be firmer, and that's a good thing. It may change colors, maybe foul smelling. That's all because they're expanding the diet, eating all these different things, more fiber, things like that. We can also anticipate, just because of the developmentally, their sleep will probably change, hopefully for the better as well. These are not signs of an allergic reaction. And then we can write these things down, hand it to them, make ourselves available should they have concerns. So when should we provide this advice? This is really where all of you are. We need all of you to make this work, because you have the point of contact with them at their well visits at 2, 4, 6, and 9 months, or in between. So this is really where we want to have these conversations, shared decision making, and meet them at those points. I don't see them until after they've had a reaction. But if you can have this conversation with them early, the earlier the better, and then reinforce this every time. So even if they come in for other concerns, we can still reinforce this, or have handouts available, or put it as part of their after visit summary or something like that. The other thing we have to always recognize would be the impact of disparities, especially on food allergies. And we know that those from lower socioeconomic backgrounds, or in certain minority groups, they have a higher risk of having food allergies. So as I mentioned before, with the different risk factors, we want to help everybody, but these are the folks that really warrant our attention. So we want to help them as much as we can, especially the African-American population. So if you have a African-American baby that has pretty persistent eczema, they're the ones really saying, hey, pay attention to me. I may go on to develop food allergies and have a very allergic life. So let's support these families and give them all that education and reassurance that we can, and help them get these foods in their baby's diet and try to prevent food allergy. I encourage you to work with allergists in your area. I don't know if you're doing this now. I hope you are, but talk to them about what happens if I have these concerns. Can we set up a good referral pipeline where they can see you within a week or two, and we don't have to wait 6 months for an evaluation, because then it's too late. As I mentioned before, incorporate this in the well child visits if you want to come up with handouts from the 2017 NIAID guidelines in the US. There was like a little infographic in how to give peanuts. So you can mix it with water and thin out the peanut butter, peanut puffs. It tells you how much to give and things like that. But there's other resources available as well. And then think about just making this part of your EHR and put it in the after visit summary as well. In Australia, they have a public health approach. So if you want reassurance about how safe this is, for years they've been recommending, they call it nip allergies in the bub. There's literally like billboards on the side of the highway and commercials, and this is just widely adopted of, it's safe. We want to feed these babies peanut and allergenic foods, and they've been doing this for years. And they've studied this, and they have not seen an increase in anaphylaxis in infants. They have not seen an increase in food allergies. To date, they haven't seen a decrease in food allergy, but that's a different story for a different time. But it's working on a public health level. So there's no reason why we can't adopt this approach here in the US when we're having these conversations during our healthcare visits and things like that. So what if we're wrong, right? We were wrong before. What if we're wrong now? So we are starting to see some interesting case reports of food protein-induced enterocolitis syndrome to causes that typically aren't known causes of FPIs, like peanut. But it's not like it's rampant or anything like that. And as I mentioned, we have good studies from Australia, especially, that are leading the charge on this, that people are doing really well. So this is something that we want to, try to promote. And even if we are wrong, and when some of these kids do develop allergy earlier, we have ways of treating that. So we're doing things like salvage oral immunotherapy. So if we have infants that do react to peanut and they develop a peanut allergy, a lot of them, if we put them on oral immunotherapy in the first couple of years of life, we can help them promote tolerance and maybe cure this. And so we have all these different approaches now that we didn't have just a few years ago. So the changing landscape, sometimes you can have food allergy despite early introduction. So when that occurs, we really want to recommend get all the other foods in their diet, and then we can address this. And as I mentioned, we have oral immunotherapy, and now omalizumab is indicated for treating food allergies for anybody down to the age of 1 year of age. And what omalizumab does is it's an anti-IgE monoclonal antibody, so it binds the IgE, doesn't care what you're allergic to. It's great for people with multiple food allergies, and you'd have to eat a higher amount to trigger a reaction. So it increases your threshold and decreases the risk for reactions from accidental ingestion. So we have a rapidly evolving treatment options available, and it's going to change even a year from now as well. What about other prevention strategies? So when we look at maternal diet, it really doesn't impact the baby, whether it's during pregnancy or breastfeeding. And I think it goes back to what we talked about before, how just very little intact protein gets passed through either the uterus or breast milk. So we want to advise families, like, eat whatever you want. By the way, what's the number one food when I ask mothers, after our conversation, what food do you miss the most? Number one on the list, cheese. By far. Number two, lattes. So we don't want to deprive these amazing mothers from their cheese or lattes by telling them to take milk out of their diet for when it's not necessary. What about maternal diet diversity when they're pregnant? It's weak signals, probably not, it's hard to tell association data more than anything. Vitamin D is not moving the needle on this. We looked at vitamin D for pretty much every chronic health condition. We can do a really good job of increasing vitamin D levels in the bloodstream by supplementing with it, but the downstream effects generally aren't there. Okay, what about cow's milk-based formula? So this goes with very early introduction. So those infants that do start on cow's milk formula have less cow's milk allergy just because they're exposed to it at an early age and they have more tolerance. The microbiome, there's a good signal there, but it's a little too early to us to recommend like stool analysis and specific interventions, but there's probably something there, but nothing that we can strongly recommend. And then, as I mentioned before, with eczema, if we put emollients on the skin from day of life 1, it may delay the onset of atopic dermatitis, but it's actually not preventing it, and it's not preventing allergies from developing. So this is kind of where we are in the prevention landscape. So lots of exciting stuff that's being looked at. Nothing that has a really strong signal other than early introduction and ongoing inclusion in the diet. So we'll have some take-home talking points, and I'm more than happy to take any questions. So we want to recommend introducing allergenic foods around 4 to 6 months of age. It's very safe. It's our best path towards preventing allergy. And as I mentioned, even though the US guidelines and the AAP hasn't changed their guidelines, and as a member of the executive committee on for the section of allergy and immunology, the AAP is not going to, because we already have other guidelines. We have the North American feeding guidelines and things like that. So if you're waiting to say, well, the AAP has to recommend this before I do it, it's not going to happen for various reasons. But we have good evidence. We have good approaches elsewhere. So this is what we want to recommend. And it's all about perspective. So nothing we do in medicine is 100% effective. Nothing we do in medicine is 100% effective. And if we look at this, more than 920,000 out of 1 million children will never develop a food allergy, regardless of when they eat it or what they eat. So I think that's important as well. So we want to recommend, let's get the food in the diet. Let's try to prevent this, as much as we possibly can, but also just reassure people everything's going to be okay. So in conclusion, we know that infants with moderate to severe eczema are those at highest risk. That's the biggest risk factor. We want to address this with them and catch them as much as possible. We want to counsel families on early introduction, make it a standard part of your visits, get your spiel going, have handouts available. And then, with this new perspective and great accumulating evidence, this is a reassuring thing. This is a good thing that we can offer families. And I hope that I gave you some of that perspective today. And I will stop sharing my screen. I sincerely apologize for that terrible interruption. Technology we're still trying to figure it out, right? But so thank you again.
Dr. Sukas, that was wonderful. Thank you. Thank you very much for that fascinating presentation. I already have questions. I'm going to start from the bottom here in the chat box. Breastfeeding and celiac disease. One of my parent concern is vertical transmission. Any research on this topic?
Oh, not
Breastfeeding
that
and
I'm,
celiac disease.
yeah, not that I'm aware of. No, I think, celiac, it can run in families. It's an autoimmune condition, as you all know, but yeah, I have not seen anything where gluten passes through the breast milk that can cause, those symptoms. So that's obviously a very specific case, and, it involves shared decision making.
Is there any rationale to the packets? Is there any rationale to the food industry's label first foods, second foods, etc.? The first foods, second foods is any rationale?
Oh, I think, it's just like most things we do in medicine, you kind of give a guidance, right? So when we think about the COVID pandemic, what we said, stand 3 feet apart. Was there something magical about 3 feet? No, but it makes sense, right? It's something we can all follow. So when you have these guidance of like first foods, second foods, it's just giving families a blueprint. Does every baby need to follow that? Absolutely not. You all know this. Is it helpful for some families? Absolutely. So these are just guidance, and we can vary from that.
Any thoughts on allergen packets, powders advertised for babies?
Yeah, there's a couple thoughts on this, and I should probably start including this in the base of my talk. So there's multiple companies that have various products available, whether it's powders or cookies or crackers, where they put very small amounts of allergenic foods, combine them, and say this makes it a lot easier to introduce these allergenic foods into your baby's diet. So one, these are costly, so it can increase cost for families. Number two, the doses involved in a lot of these haven't been studied as a way to actually prevent food allergies. So if there's micro dosing, is that actually enough? Number three, some of these products that when they study them off the shelves, they don't actually contain what they say they contain. So I don't want to introduce conspiracy here, but it's like every other supplement out there. We don't quite know what's going on in there. And then lastly, we still don't want to get away from feeding babies. We want them to learn how to enjoy different tastes and textures and the nutrition that comes from that. So is it necessary? Absolutely not. Would some families like to do that as part of their early introduction plan? That's fine. But I can't recommend one specific one over another.
There's a question about anaphylaxis. Do we consider generalized hives plus the GI symptoms such as vomiting, anaphylaxis?
Yeah, so when we talk about anaphylaxis, it's more than one body system. So hives and vomiting, that's anaphylaxis. It's important to note that there's a range in severity. So a lot of people have very mild anaphylaxis. They break out in hives, they vomit once. That's anaphylaxis, but oftentimes it's actually self-resolved. So you can have more moderate and severe as well, but it's pretty unusual for infants, especially, to have true severe anaphylaxis, especially with respiratory involvement. When we think about respiratory involvement with anaphylaxis, it's almost always going to be those with underlying asthma, specifically poorly controlled asthma, and then they get the bronchoconstriction, and because they already have hyperreactive airways. So that's typically when we see it. The whole concept of like your throat swelling shut, it's such a rare phenomenon. So we want to reassure families with that as well.
There's a comment by Dr. Weimer, but I think there's a question. How much allergy is prevented by no food until 6 months? Many babies with cow's milk problem did well on goat's milk.
Well, yeah, so it goes back to what's the diagnosis. So what's the reason for avoiding these things? So if you have a true, like an IgE mediated milk allergy, you generally need to avoid all mammalian milk forms of milk because there's cross reactivity with those. So a lot of this too can be tincture of time. So whatever's going on with these babies as they are developing, and it just naturally resolves no matter what you feed them. So I think this whole concept is just, we don't need to go their entire first year of life and avoiding it. If we truly feel that cow's milk is causing issues, all right, let's avoid it for 2 to 4 weeks and let's reassess, and then think about putting it back in the diet if they're doing well.
Please mention a little bit about, I think, food-induced enterocolitis. Any approach other than avoidance of the food?
Yeah, so FPIES, food protein induced enterocolitis syndrome, the most common presentation, it typically occurs in infants or young children. They eat something, they're completely fine, and then typically 2 to 3 hours later, they have profuse vomiting, sometimes followed by diarrhea. This is not IgE mediated. There should not be hives associated with this. There's no diagnostic test for it, which is really hard. You almost always have to have 2 episodes or more to establish a diagnosis, because there's a million reasons why babies can vomit. And these foods are very different from IgE food allergies. So now we're talking about cow's milk and soy are more common because of formula based, but now we're talking about rice and oats and vegetables and things like that. The good news is this is often self-resolved, and it gets better as kids get older. It also doesn't cause anaphylaxis. We don't need to be prescribing EpiPens or things like that. And it's typically only one food. Rarely is it going to be 3 or more foods. So if you start thinking there's like 6 foods causing FPIES, we need to reconsider the diagnosis. And then as far as there's questions we don't know. So like we know with milk and egg allergy in babies, 75% of them can tolerate it when you bake it in things, because when you heat it in the oven extensively, it changes the protein structure and they can tolerate it. It's likely the case with FPIES. We just don't have good evidence for that. It's very unlikely that they're going to react to trace amounts cross contact, and it's very, very unlikely that it's going to be transmitted through breast milk.
Any other questions, comments for Dr. Stukas? You can ask him question directly or put them in the chat box.
So I know this topic tends to be not controversial, but it's very different from what many of us have taught and practiced. And I encourage you read through the guidelines that I shared with you. Again, this isn't just my opinion here. I'm just merely relaying what the evidence shows. But yeah, it's interesting stuff, and it's relatively good for the most part.
David did a question here. What about the premature, well-appearing baby with bloody stools?
Yeah, it goes back to I think we need to question, why do we think they have that? What's going on? There's a differential diagnosis for all of these symptoms. If we do think it's cow's milk allergy, again, go through a trial elimination. When it comes to cow's milk induced proctocolitis, we need to give it like good 3 to 4 days to heal. So I think it would be harmful to tell parents it should be clear by the next diaper if you take milk out. We want to give it 3 or 4 days. It's a benign condition. It's often, it's self-resolved even if you continue milk in the diet. So we want to reassure. It's very unsettling when a parent changes the diaper and they see that, right? But that's something where we can say, okay, if they're otherwise acting okay, let's give it some time. Let's see if we can make this resolve by changing from a cow's milk-based formula and go from there.
Any other questions, comments? Dr. Weimar, go ahead and ask your question, please. You're muted. We don't hear you. So you may have to unmute yourself.
Okay. I'm not sure how to do that.
Yeah, we can hear you now.
Oh, okay. I just thought it'd be interesting for students to understand the history, the reflux boondoggle, and that started about the 80s when they did go or recommend no food until 6 months, because the problem was until that, for probably a century, all babies started food at 3 months. So when they changed to no food till 6 months, the babies were flat hungry. And the reason they spit up is because they took too much milk. And they keep taking milk, and finally they spit up. Some of those babies did reflux, but the reflux, of course, diagnosis, and then they started the string test for stomach acid, if you remember. But that whole reflux boondoggle was due to going to food at 6 months. And of course, my question is, statistically, just how much allergy is prevented by not feeding till 6 months? Was that ever shown to be significant at all?
That's a great question. I don't believe that was looked at. We didn't really have good evidence on this until that LEAP trial showed in the prospective manner about how to prevent it. But I mean, you're right. So that's a good question. And I appreciate your perspective on, well, just infant feeding in general, right? There's an ebb and a flow to all of this, of whatever is the pervasive trend in that particular time, and then how that influences things. So I think I think the best comment I can provide is it's always healthy for all of us to look back at things and with a healthy dose of skepticism and say, what does the evidence actually show? And, you know, it's interesting how we got to this point. Where are we now? Do we need to change anything?
Right. Yeah, I'm suspicious about the immune system being affected by agriculture. In other words, agriculture has taken all the trace minerals out of, so everybody is to some degree deficient in zinc, for instance. Of course, in the past, people have been using colloidal silver to affect their immune system. That's not, nobody does research much into things like that because there's no money in it for the pharmaceutical companies, and they're the ones who are mostly financing research. So that's a problem with the whole medical profession in general. We are so married to being financed either by charity or by pharmaceutical companies, and so that directs research to a great degree nowadays. I ran across an article in Pediatrics in 2013 that said that 40% of mothers were starting their baby foods before 4 months. So in other words, even though the pediatric academics have been advising about not feeding food till 6 months, I don't know if it's a lot of pediatricians who make that decision or mothers. Of course, what we used to do to treat reflux was thicken the formula with rice cereal, if you remember that. And I never knew how much rice cereal to tell mothers to put in the milk. And then I had a baby one time in the hospital that was about 6 months old with some other, I think gastroenteritis, something like that. And I asked her, well, how much rice cereal or rice do you put in the milk? And she took the top off and turned the thing upside down, and it ran out of there slower than ketchup. So she kept, titrating it. And by the time she got enough rice cereal in there where the baby quit spitting up, it was, of course, the thing is, she was still delaying foods, taking the advice. Back then, the advice was, I don't know, counterproductive, and it took either an alert doctor or alert mother to figure out this was bullshit.
Okay, we have okay, thank you, Dr. Weimer. We have two more questions.
Just my views, but that's it.
Okay, so we have a follow-up question on premature well-appearing baby with bloody stools. How long would you keep them on non-cow's milk formula, and would you use soy formula?
Yeah, I think you can go to soy. We were all taught there's a ton of cross-reactivity between them, but they're different. Soy is a plant-based, protein. It's very different than the mammalian protein. So you can go to soy first. And then the recommendations now are, let's go for a 2 to 4 week elimination and then reassess. If symptoms are completely resolved, you can put it back in the diet and see if they come back again. If symptoms aren't resolved, you can consider putting it back in the diet because that probably wasn't the cause anyways.
And then one more question. Should patients with peanut allergy avoid foods that are prepared in the place where they have peanuts, but the food does not have peanut? I think it depends on how well the manufacturer avoids cross-contamination. Some patients avoid it and others don't and are fine.
All right, so very quickly, in the United States, if a food contains one of the top 9 food allergens, milk, egg, wheat, soy, peanut, tree nut, fish, shellfish, or sesame, it must state contains. All of the other wording, may contain, process and facility, shared equipment, is not regulated and is not meaningful. Very few of those products contain any allergen, let alone enough allergen to trigger an allergic reaction in an individual. So the vast majority of these are safe. We have also understood a lot more about individual thresholds And most people with peanut allergy need to eat a whole peanut before they have any reaction at all. So there's a lot that goes into this, but for those precautionary labels, those are generally very safe. Now, some people choose to avoid them just to eliminate all risk, and that's fine, but that's a conversation we have with folks, and they can make up their own decision.
I think that's it. I don't see any other comments or questions. Dr. Strukas, thank you very, very much for that wonderful presentation. Really appreciate it. And thank you all for attending this morning's Grand Rounds. We'll see you next Friday. Have a wonderful Friday and a wonderful weekend. Thank you.
Yeah, thank you so much.
Thank you.